Okay, we're going to get started now. We have, this is kind of a fun session. We show sort of therapeutic challenges or dilemmas. Jeff, yeah, come join us. For this case, we have therapeutic, we get advice from therapeutic experts. So we have Dr. Flores, Dr. Headrick, Dr. Moghanaki. Dr. Reisman had to leave, so we need another therapeutic expert. So I think Dr. Yip will come and, no, I'm kidding. We have Jeff Yang has graciously joined us. Dr. Altorki, are you going to help ask questions for this case with me? I don't mean to put you on the spot. I think this is, by the way, one of the more fun things that can happen at a conference like this. I'm showing a case now because as we were presenting the first session on surgical thought making or how they decide things, one of my former fellows from China said, "Oh my God, I have a case that I need you to see." So I literally was sent this case by WeChat 10 minutes ago. And I think it's just a fascinating case, and it's a real struggle. This is a 37-year-old woman. They want to get some advice from a panel of experts, and you can see it there, right, everybody? So this is a 37-year-old female, and she's telling me that this person is, very healthy. Had these 3 lesions in the right upper lobe. This is the top row. There's my top row is at baseline in 2020. A couple of years later, each of them got a little bigger, and they were operated on, and they were minimally invasive adeno or adeno in situ. All 3 of them were adenocarcinoma type lesions. So now some time goes by, and we get this. There's a little spot. Here it is. And in 2022, it's a little bigger, and now it's a little bigger, and now it's a little bigger. And I said, "Did they biopsy?" She said, "No, there's nobody that can do this kind of biopsy at our institution." So they want to treat this. They want to treat it, and they want to know what's the best treatment or what to do. So I now have 4 experts here that have heard the first lecture, and I say, this is really an interesting problem. Who wants to start? You want to start, Raj?
So first one had those 3 little GGOs, and they did a right upper lobectomy.
Yes.
I would not have done that. Yeah, when I look at this, I see a 37-year-old woman with some, maybe carcinomas in situ, things that I
Actually,
would
I'm
describe.
sorry, Raj, I'm sorry. It says it was wedge resections. Right. I'm just reading it also.
Okay. Either way, I still wouldn't have operated on that patient. When I'm looking at someone who's at risk for developing a lung cancer, I want to identify cancers that I think are going to kill them. Cancers that are fast moving. Those are the cancers that made the difference in the NLST trial and the Nelson trial. This to me just indicates this patient's at risk of developing something. I want to keep following her. And if she develops, let's say, a solid lesion somewhere else, then that's what I'm going to go after. I'm going to keep an eye on these and make sure they're not changing into something. But if you start taking out lung left and right for these things, when a real cancer that's going to kill them, where you can really have an impact, shows up, you may not be able to do much. So to begin with, I would have left those alone. I would have continued to watch them. And that was my point about localizing tumors. If you really have to localize something like that to get it out, chances are it doesn't need to come out at that time.
Now you're developing what looks like, now you're developing something that looks like a solid lesion in that right lower lobe. And it's clearly progressing each year. I don't know what the doubling time is, but it's, it's 800, it's relatively slow. She's giving me the doubling time is 800 days. So it's relatively slow, but you can see the difference from here to here. Yeah. 5 years. So so we're in the
George.
situation where it is, no, it is slow growing. There's no question. I'm not sure that that's malignant, but she's already had a malignancy in the upper lobe. Now she's got something that's growing slowly in the lower lobe. Probably a pretty good chance that it is, a slow growing adenocarcinoma. Do we treat it? Jeff, what do you want to do? Do you want to
Claudia has a comment.
biopsy this? It was there in 2020, but I guess they either didn't see it or it was so small they ignored it. But it's there, and it's clearly, look, it's clearly getting a little bigger.
I agree with Roger.
Anybody else have any thought? You just want to keep following that? It's solid and it's growing. These last 2 years, look at these two, this one to this one. I mean, you can't deny that that's getting a little bigger and it's more solid looking. Any other thoughts? Rob, what would you do in Tennessee?
It's like there's a little bit of ground glass around it. I mean, it's more solid than the other lesion, but I would be suspicious of a multifocal process of well-differentiated adenocarcinoma developing. I wouldn't have taken out the first lesion either. But if I was seeing this, maybe a point now there's 2 lesions, we would, through a cone beam robotic navigational approach, you can get these lesions, you could biopsy them. So in our center, we would biopsy both of them and look for EGFR mutations if you're starting to see multiple lesions. But I'd be hesitant to treat her at this point. Yeah. Knowing that its growth rate's really slow. Surgically to excise that, you're going to take a lot of lung tissue. And then the other option is you're going to radiate it, but then you're radiating a tumor without a diagnosis, and then it leaves you with sometimes a harder area to follow afterwards. But
yeah, I totally agree. So this just came out maybe a couple weeks ago, and I think the published proof is not even out yet, but in JTO, there was team from China with Haikuan Chen where they looked at a study of multifocal adenocarcinoma. It was a prospective study, single arm, and the protocol was anything that was less than 2 centimeters or had anything less than 2 centimeters with a consolidation to tumor ratio of less than equal to 0.25. So basically something that is very much not solid. You can their protocol was you just watch it, and then if it gets to be more solid beyond 0.25 in terms of the C to T ratio, or if it gets to be greater than 2 centimeters, then that's when they would operate. And for them, the 8% progressed, and they only did 8 operations out of 446, and their overall survival was 100%. So I think this case roughly fits that category. In that study, there was 3. You need to have 3 or more of these part solid nodules. So I think based off that, it's probably safe to just watch this. This is still really small. So
About the first or the second case?
I'm talking about for both. Yeah.
Yeah. Well, there's certainly a change, because I know when I visited Fudan just before the pandemic, the argument was, these are going to become cancer, so why not take them out? And they were taking these out a lot.
Yeah.
So I'm glad that the things finally moved in the right direction.
Yeah.
The second one, though, it looks to me like it's more solid than not. So it's a different, true enough, it is already, she has a 5% survival, 100% already without treatment. So the question is what to do with it, and would you biopsy it at least?
Well, they're saying they can't biopsy.
Well, regardless of what they say, would you biopsy? Is there enough suspicion there that you would biopsy this lesion by some mechanism?
So I look at lung cancer as a multidisciplinary approach. And so I don't like to speak about what I would do. So what I'll describe is what our institution would do. We biopsy these things. We don't have any concerns about hitting it with robotic bronchoscopy, and we would want tissue. Could this still be benign? Yes, this could still be some sort of an evolving benign process. And if the biopsy provides some reassurance of some sort of benign process, we stop. At least then we know. But if it does show an adeno, this is the type that can metastasize. David slides showed that every millimeter matters. There's a reason why you have a high relapse rate in 1As. And so in our West Coast institution like to treat these things. Now, how do we treat it? We do believe a lobectomy for something like this is too much treatment, too early. We are uniquely poised in that actually we've been doing thoracic ablations predating SBRT. So Rob Subb back in the 1990s was developing it. So we have really good outcome with sub-centimeter tumors. In fact, we have a publication right now showing 100% local control in about 100 patients with bona fide biopsy-proven stage 1 lung cancer, less than 1 cm, within 2 cm of the chest wall. Once you have to push the needle a little bit farther, we feel like sometimes the needle is maybe not in the right place. And so that's when we start to see higher failure rates. So we don't lump the whole thing and say, you have a 20% failure rate, because that is what the data shows, but in highly selected. So the name of the game is selection. So for this thing, would we freeze it? I think we'd be okay freezing it or SBRTing it, but we wouldn't do it without a biopsy. And our team would push to biopsy this thing. I don't think this would go to a 6-month scan.
And they say it cannot be biopsy.
They say they don't have anybody that can do the biopsy of this lesion. So now let's just say we say, watch it, and it gets again a little bigger.
Can you clarify that? Is it because of the patient's morbidity or the technical ability?
Technical. They have nobody that can do these kind of small biopsies. I guess they don't have robotic bronchoscopy in this region. So they're stuck. So now they want to know, should we watch it? And right now, nobody wants to do anything. But if you watch it, I would pretty much guarantee this is not going to stay still. This is going to get a little bigger on the next scan 6 months from now. So at what point do you say, let's do something? And what would you do? Drew, it sounds like you would do.
I would add one more
Drew, it
thing.
sounds like you would do something like cryo for this.
Well, for our multifocal patients, we're actually getting ready to open a study where we want to just treat these patients with non-surgical treatment, because they often have 10 to 20 years to live. And how many resections are they going to need? I've got a patient right now with 14 lesions, and we're just picking off one at a time. Could they be fine to observe? We actually observe the non-growing lesions. And then when one of them grows, the solid component grows, we go ahead and treat it. And, they've done cryos in up to 25 targets before. Patients still breathing fine. So there's less injury with cryo as there is with SBRT. And if you start doing, 5, 6 SBRTs, you're starting to trash the lungs. So just like we don't want to cut out too much lung, we don't want to trash the lungs. And so I think we put everything on the table for these multifocal patients. Regarding, molecular subtyping, we definitely want that information. It gives us a sense of CNS mets. We know that EGFR positive tumors like to go to the brain, even in early stages. But our medical oncologists do not give systemic therapy unless it's node positive.
So what if the physician interventional pulmonologist in your institution is doing the navigational bronchoscopy and says, hey, it's malignant, and while I'm here, I'm going to drop a non-thermal ablation probe with galvanize or allele. 7 millimeters, really easy to hit.
Yeah, we need
Would
some,
you
we need some
support that?
clinical data with their devices. Although the energy is the energy, so it's hard to push back. I don't know.
Would anybody get a PET scan on this woman at this point?
That's a good question.
No?
I wouldn't.
If you,
No.
if,
I wouldn't, but we do.
okay. If you decide to write back and say, we'll watch it, when would you repeat her scan?
You get 3 millimeters growth in over that time span,
5 years.
5 years.
Once we think it's cancer, every 6 months, it's a lot of scans.
A lot of schools.
What do you think?
I don't think there's a great answer for this. I think this is the kind of situation where you talk to the patient and you do present.
Seems to me like.
It would be pretty safe, I think, to follow.
Yeah, it seems that it's picking up some speed between 24 and 25 compared to prior years. So maybe time to shorten the intervals.
How would they treat it?
And even let's say we did the biopsy, let's say we convinced them to fly to Drew's expert at UCLA and they do a bronchoscopic biopsy and they get an answer. How would you treat this anyway? And that's sort of still the question. Would anybody do anything?
That was the previous session.
Would anybody do anything other than surgery? No. Or would you take into account that this is probably she's 37 years old. She's going to develop more, right?
Why is that? Why do you say that?
Well, she's already had 1, 2, 3 or 4 already lesions.
Is she the same patient?
Yeah, this is the same one that had the.
So 2 different patients.
No, this is the same patient. She's already had 3 lesions in her upper lobe that were wedged out. Now she's got this lesion in her lower lobe, and she's going to get more. I think that's,
Claudia
so now you're really into lung sparing, right?
Yes.
Claudia had a good comment. Is there anything on the left? Don't we see the,
As far as I know, no. It's all been on the right so far. Tough decisions.
David?
Okay, Fred, you want to,
Since
you want to
they,
tell us the
we
answer?
have we have a panel of master surgeons who said they would not have done the right upper lobe a couple of years ago. Now, if we make it, if this thing grows and it's 1.2 centimeters, you're going to do the operation next year. What would you do at the time of surgery for those 3 lesions in the right upper lobe? From a master surgeon technically.
Well, I mean, look, they were 3 non-solid lesions. They were growing. They probably didn't see this tiny thing in the lower lobe at the time. And they said, let's wedge them out. And I think that's what they did.
Asking a radiologist, I
No, I'm
want to
saying
hear
that's-
from
I'm
the
saying
surgeons.
that's-
Okay.
No, but that's what happened. So yeah, they can,
I wish I could talk to him that way.
See, I'm a little more reluctant to touch it because of the prior surgery. If the patient didn't have that prior surgery and I saw this, I'd have David biopsy it. If it came back as negative or inconclusive, then I'd continue to watch it. If it came back as a cancer, then I'd be aggressive about going in there to get it. I bet you could wedge this, even though I know everyone's thinking in their mind, lobe, lobe, lobe. To wedge it, you may need to do a thoracotomy to get it cleanly. You may not be able to do that thoracoscopically or robotically or even with the fiducial or whatever. But because the patient had surgery before, I would not go in there without a diagnosis of cancer. So they removed them already, but if it was there, I would leave them. Yeah, I'd leave them.
Jeff?
So were there 3 or is this just 1?
No, what would you, if you?
Can I see the previous one?
Show it again.
Yeah.
maybe.
Okay, so you're showing just
One,
one
no, no,
right now.
Yeah, they're different lesions. 1, 2, 3.
Are they different? Yeah.
Yeah, this is all time 1,
Yeah.
top lead, top.
Oh,
I see.
okay. Oh, I see. You're showing 3 different lesions. I think in this case, I'd probably leave it if it looked exactly the same as this.
We'd freeze
What
those.
would you do? If you went in to remove the bottom lobe? The question is, if you were going to operate on the bottom one, what would you do with these? Leave them or take them out?
Yeah, for me, I would leave them.
Am I getting any traction on freezing? See how it's easier to just to freeze and send them home?
Yeah, she's 37 years old.
And it's not
Yeah.
radiation, so we don't have a carcinogenesis problem. The scar after cryo, when it's successful, is very easy to monitor. And from multifocal, we prefer it because the parenchymal scarring from radiation can make surveillance difficult, and we don't want some new cancer growing in the scar that we can't see.
I would like to know more information about the biology of the tumors, because that could predict the behavior, the future behavior of the new nodule. Since it started as a GGO or a partial solid nodule, maybe it could represent the same biology of the first tumors and grow really low. Slow.
What information would help you to determine the biology of the lesion?
Well, to know if there is an AGFR mutations or any other mutations, ROS1.
So
KRAS.
you want a biopsy of those lesions first?
Oh, maybe know first of all the biology of the first tumors that were removed in the past.
Ah,
You know,
One is, it's 2 actually, for sure. It's MIA and AIS. That's what they want.
the one thing you touched on before was a PET scan, talking about the lower lobe, not for the upper lobe. I would get a PET scan because if it does light up, I'm thinking small cell. And when you look at the I-ELCAP data, the small cell lung cancers that were removed, I think had a 90% cure rate. So I think you got to also have small cell in the back of your head when you're looking at these things.
Excellent point, Raj.
Let's move on. I think we've covered this. One more question or
Um,
comment.
With proton therapy being available, what's the perspective right now, especially?
There's no measurable benefit with protons. I've never referred a patient for protons.
Say margin.
No measurable.
No measure.
In
Oh, is it
fact,
because-
a recent proton photon trial was reported for breast cancer, and we were seeing more rib fractures with protons. So choose wisely.
That's a bit counterintuitive though, because I guess proton is meant to be more focal without the,
It's actually not. It's actually the blast zone, the high dose zone is actually bigger because of the way that matter interacts with air. So the low dose is less, but the high dose is actually more. So it's theoretically possible to be more side effects with protons. Not measured though, but theoretical.
Okay, now we're getting to my cases. That was our outside case, and we saw the struggle with getting a firm decision for what to do. This is a case. This is a post right upper lobe part solid wedges. So this is the lesion. This was wedged out in the right upper lobe. And now on October 24th, we see right next to the suture line, we see that little spot. And now 6 months later.
Since the surgery, since
Sin-
the index surgery.
Yeah, this was
The original.
index surgery was February 24, October 24. So 10 months later, that's the little spot next to it. And now 6 months after that,
Yeah.
5 months after that, we've got that something there. So the question is, everybody can take out their Mentimeter, see what they want to do. Should we biopsy this? Should we get a PET CT? Should we just resect it? What does everybody want to do? It's interesting. So nobody wants to resect it. Most people want to get a PET scan. Oh, we got a resection in. Okay,
Take it out.
so,
Take it out.
okay. So we got a resection. Do we want to discuss it now? Let's just discuss it before I show you the next slide.
Do you have any other projections, coronal?
I mean, in a case like this,
Mhm.
are you confident? I mean, it's kind of the parallel to the other situation, you know. I think everybody, at least I'd like to hear from our therapeutic experts. Are you guys all confident that this is something bad, or do you need more before you do anything? You
Bad?
definitely want to biopsy this? Do you want to get a PET scan? Do you want to do more right now? How confident are you that this is going to be something bad?
Oh, yeah, go ahead, Jeff.
I- Yeah, I'd like to get a PET scan to take a look, but obviously my suspicion is very high.
It's got to be obvious.
And nowhere.
It is Abbott, right?
It's gonna be-
Yeah, so I would assume that that's a recurrence, and so depending on, assuming the patient's still healthy and fit, I would take it out.
I think I would encourage a salvage lobectomy. That can come out with a lobe, right?
Yeah.
That's what it's going to be. Yeah, I asked about the surgical option. And then in the MDT, the pulmonologist can weigh in on that as well. So if they're fit, just take it out. But if maybe they only had a wedge because they were borderline, and then you can consider alternative options. I don't think they can freeze this because it's too close to the blood vessels. We actually have a percutaneous radiation brachytherapy technique that we use. We're publishing our second manuscript. We have 98% local control for these high risk areas. So that requires about a 4-hour procedure. So you put the needle in and then you dwell an iridium source for about 10 minutes. So that would be on the table for us.
Well, I would assume that the initial operation, which was a wedge excision, was done just because of the small size of the lesion and maybe inadequate margins, but it's a pretty early recurrence. I would want to make sure that this isn't a really aggressive adeno, that there's positive nodes. I would biopsy it and do the EBIS with it, make sure I'm not dealing with something else that's gotten away from us. And if not, then go on with lobectomy.
So when I look at the primary lesion, I'm surprised a cancer is going to give you this finding. Let's say if you didn't take it out, do you think you're going to see that a year later with a lesion like that?
So I think we've looked at these peri-staple things, which can sometimes look pretty scary, like this one does. And there is at least a third of them, if not more, that are granulomas. So I think biopsying them may not be the worst choice.
So now we have a third time point and it continued to get bigger.
So David, you were the first person to teach me how aggressive these staple line recurrences can be. And so thoughts on how many lymph nodes to take out to make sure this patient's not metastatic or not? And is this someone who should get systemic therapy either way, even if they're lymph node negative?
Well,
do you send to med-onc?
Surprised you didn't biopsy it before you went for another scan. Why not?
I'm just showing the case.
Did
It wasn't referred to me. No, it wasn't referred to me.
It's not.
They didn't take.
Not my case. It's one of the surgeon's cases.
No.
And this is now October. I think it's now scheduled for biopsy. But they waited another round before. So you can see it got bigger. Okay. So now it's scheduled for biopsy. Anyway, let me show you just some fun cases. This one.
The other thing that popped in my head, David, is if this patient had a needle biopsy preoperatively, did that needle go through that area?
Here's just a fun case. You know, this is a baseline screen. This is a baseline screen. Yeah, good question. Baseline screen. Everybody, this measures 5 by 4 millimeters. Baseline screening exam. Everybody comfortable saying, well, less than 6 millimeters. Everybody recommends come back in a year, right? Look at that mediastinum. I mean, this is, this is the exception that proves the rule. There's this massive lymphadenopathy and the lesion grew. This turns out to be a small cell.
This is what we treat.
Yeah, but this is the balance we make in screening. This is where
safely.
The world has made a decision that you can't chase every 4 millimeter nodule on the baseline round. You just can't. With the acknowledgement that you're going to get these kind of cases once in a blue moon, that it's just, had we treated it right then, probably could have done pretty well.
So
A year later, that's it.
yeah, if I saw the patient in clinic with that scan, I wouldn't wait a year to scan them again. Yeah,
Would be the right.
I'd probably wait 3 months.
I-ELCAP.
No, there's on a screening case, every baseline screen, if you lung rads, I-ELCAP, British, every protocol says come back in a year. There's nobody.
Yeah, I'm just saying, me personally, if I saw a scan like that,
Why?
well, so just
You can tell.
it's
Why would you be willing to go against all of the guidelines?
Because he can
Tell
tell.
us, Jeff.
because it's just it's completely solid patient, 30-pack year smoking history. If I saw a nodule like that, I would not wait a year to rescan it.
Guidelines are guidelines.
It depends on a patient. If the patient's like 75 years old, who had quit smoking 50 years ago with a scan like that, I think that's different. But a 61-year-old with a 30-pack year history.
That seems like a very reasonable position to take. I think there is the screening, and then there's you sit in the room and you say, you're 65, you smoked a bunch.
Yeah.
Get the scan earlier.
I mean, this is right. This patient was probably already lymph node positive and could have gotten,
Huh?
the patient was probably lymph node positive. It could have gotten drugs and surgery. Now that looks like a chemo rads, tough case now.
And he may not make it even with surgery had he been operated in the first place. So,
So here we have a nice non-solid nodule. It's on PET scan. It's a little bit hot, which actually hotter than you usually see for these non-solid lesions, and went for surgery, had it wedged out, I believe. Yeah, wedged out. And now take a look at what's going on here. There's actually a couple of lesions here, very small Here's a couple more non-solids. They were not there before surgery. Now you've got at least 4 non-solid lesions in that lung in there. This is, no, they grew, sorry. There's at least 2 here or 3, and they're growing over time. They're getting bigger. So this is post, had a non-solid. Now you have, after surgery, you've got a bunch of new ones in that lobe. What to do, and what do you think these are? Do we want to call these new primaries? Do you want to call these Mets? Do you want to?
Is this a poll question or is this?
No, I just want, we're already out of time. So I just wanted to get the feeling.
You know, some people talk about biopsy and comparing NGS. I don't understand them. If it's a GGO, they're new primaries, right?
Are they?
I mean, do Mets look like GGOs?
You can get endobronchial spread. You can get endobronchial.
Do they look
spread.
like this?
It's too soon. I mean, to me, I'm worried that that's what it is. That this is metastatic disease, but endobronchial spread, metastatic disease. I've had, I don't like to admit this too loudly, but when I've done biopsies on these and there's a blood track, I've had cases of non-solids where all of a sudden you see along where the track was, a couple of things that start. So I'm thinking that that's what this might be. I don't know for sure, but now you've got this. So do we start thinking of, those as being like real metastases? Are we starting to think of chemotherapy? Are we starting to think of just do a completion lobe or another set of wedges? You know, it's a challenging case. Dr.
Our team
Altorki?
likes to give the benefit of the doubt and think it's local only and stick.
I'm thinking these are independent primaries and I would do a completion lobe. How old? 65, good performance status. Completion lobectomy, I think is the right thing here.
Yeah.
In my opinion. In my opinion.
Anything afterwards? Would you do any chemotherapy or anything like that?
Depends. I mean, if the pathologist thinks that they're 2 distinct primaries, and especially if they have different mutational profiles, then nothing. I mean, the fact that he's had a prior cancer and now has those completely raises the chances of this as being just as multiple primaries.
It's pretty fast to come up like that.
Well, maybe.
These non-solids.
But you know, the growth rate is totally unpredictable. It sort of varies. I mean, they're not all uniform.
Okay.
Do patients with previous lung cancers who get metachronous new lung cancers have faster growth rate in the new lung cancers?
I haven't seen it. I mean, I don't know that. I don't know if that's been reported.
Okay.
This one bothered me because they're pretty fast.
What I'm saying is that if you had a history of lung cancer and you had a ground glass lesion develop, it's more likely to be malignant than not in a patient with a prior history of lung cancer.
So what did you guys do? This was July. Did you treat them?
This is what it was.
So what did you do?
That's what it was. This was wedged out.
No, the next time, the second time, what did you do? Did you do
It's being
anything?
followed now. Right now, it's just being followed.
Well, the recommendation of this panel is to do something.
Do something.
This is kind of hot off the press. But this is being, right now.
We would either freeze it or we can SBRT both in one session. And actually, we now do SBRT in one treatment. So
I think the good news is it's probably not going to hurt by following it. They're completely non-solid.
SBRT
So,
either.
you know, but
It's a safe
eventually
place to
we have to
SBRT.
do something.
We would consider it multifocal disease. This looks like the guy's just starting to explode. We see this often in the South and you'll end up with 50 lesions pretty soon.
Yeah.
We would biopsy it, I don't know what his lung function is. I don't know if he could even tolerate a lobectomy, but we would biopsy it and then look for EGFR mutation, even though he's a male and a smoker, occasionally you still see it. But I would bet if we keep watching, he's going to explode everywhere with these lesions.
What I'd be curious to know, David, that graph that you put with the delay and the effect on survival, how is that in someone who's had a lung cancer removed before with these lesions?
These lesions don't, for these lesions, the size really doesn't matter. This is independent of size. We've seen 100% long-term survival, regardless of the size of these lesions.
Why not watch that?
You can watch. That's what I'm saying. In my mind, it's completely safe to watch this. They'll get bigger, but you know, you could watch it till it starts really changing, and it won't change rapidly.
And
think
that's
it's
my
really
argument
unlikely.
against the
But
law.
this is a really unusual case.
But that's my argument against the lobectomy. So if this patient's at high risk of lung cancer, who's to say that another solid lesion or even a small cell pops up on the right side, and now you've already done a
So when
lobectomy?
would you repeat the scan?
6 months.
Okay, I'll buy that.
I mean, Nasser, your data from CLGB study is 3 to 4% a year linear. So,
Yeah, the solid tumors,
yes.
solid tumors.
Oh, so these guys don't have the same rate? What would you quote the rate of more?
And I don't know the rate for that, but you know, these are subsolid lesions. One of them is solid, but
No, I think there's maybe a little
Solid-ish.
something in there. I
Yeah.
can't tell. But whatever. Okay, thank you very much, panel. That was some interesting discussions.